Thank you all for joining us. I'm really lucky to be at Changing Faces tonight with Abby and Amy, and we're going to talk about our tongue and lip ties and our baby's general dental and oral health and well-being. So we're pretty lucky to be here with these ladies tonight. They've got a huge amount of experience. So Abby has done a huge amount of training. So she graduated back in 2011 with distinction in dental. So she's got a huge amount of knowledge. She's even started her studies with this Australasian dentistry.
Yeah, just done my primaries to become a fellow. That's fine. Fellowship.
So she works here at Changing Faces in Hamilton and has a huge passion for children and babies, oral health, and taking a really holistic approach to seeing the overall picture of what's going on and how they can help babies and their families carry on, especially in their breastfeeding journeys. They do a lot of preventative stuff here at Changing Faces as well, which is a really interesting sort of measure to take in dentistry. It's not always the sort of norm with all dental practices. And Amy as well, she's got a huge interest in our babies and their families. Tongue and lip tie is your specialty, so I've heard. Yeah, and she's done heaps of training in this field, so it's going to be really interesting to talk to these ladies tonight. And if you do have any questions, please put them in the comments. We will do our very best to get to them as we go, if it's something relating to what they're saying, or at the end we can cover off any other burning questions that you have. So it's just a nice casual chat, and I'll hand it over to these guys.
Hello, so I'm Abby. I just thought we would start with a bit of background and then give you guys a chance to ask any questions. Some of the things I say you might bring up some questions, so feel free to pop those in the comments, and we'll probably get to them at the end, I think, Amy and I. So we'll try and show a few photos up to camera as well, which we might post later, just because it probably does help with this topic, but let's just get started. Excuse me, I do have some notes, so just to keep me on track. I thought I'd start with just a bit of a definition of actually what a lip or a tongue tie is. So when a tongue basically develops, it has actually attached to the floor of the mouth, and basically as your baby grows in utero, that attachment reduces. But if it doesn't reduce completely, then it basically causes restriction under the tongue, which causes problems with function and reduced mobility. Okay, so hopefully that's a bit of a simplified version. And basically the same with the lip. If that doesn't reduce back as well in time in utero, then it can be too short or too attached too far down, and also cause functional problems, and then it's considered lip tied. You do basically the same as the lip. You can sometimes get these on the cheek as well, either side. So problems that these can cause, obviously people are aware that it causes breastfeeding problems, but it can then go on to cause speech problems, eating problems, dental problems, including things like decay, crowding, gum disease. It can actually cause postural issues and sleeping issues, reflux, not just in babies but in adults, and indigestion, sleep apnea, and SIDS. So just to name a few. Probably there's kind of a lot more going on, but yeah, not just the breastfeeding problems. So sometimes people ask, how do we get to do this as dentists or get into treating babies? Because not many dentists do it actually. In New Zealand, we have people come from all over New Zealand, actually even from the South Island, to come and be treated here. So I wanted to share a little bit about the story of how we got there. So like Laura already said, we take quite a holistic approach. So we look, as dentists, we actually want to kind of create or see you grow to your optimum. So we're looking at your aesthetics, we're looking at your oral function, how you bite, how you breathe, how your jaw joint works, whether your posture is good, and also looking at your nutrition. So we try and look at a broad picture of your oral health, not just do you have any decay in your teeth. With that, it's led us into, we do quite a lot of orthodontic work and myofunctional work at our clinic. And so previously we really were only able to treat kids probably from about the age of 4 or 5 years old and older. But as you can imagine, we have a whole range of families that we see, and these children had siblings that were being born, and mums are like, well, you're telling me that my 6-year-old is tongue-tied and needs some treatment. It's my baby tongue-tied, and what can we do about it now? And so basically we extended ourselves and got a lot more training internationally. So one of our dentists has been to America, we've been to Australia, we've done courses in New Zealand as well, basically to get ourselves as on board with getting the procedures right and doing it the best we can for our patients, so that we can actually get things correct from the start and hopefully even avoid having to do any kind of orthodontic or orthopedic myofunctional work as they get older, or at least minimally anyway. So I thought I would go into a little bit about what we do and what we look for in our older kids as well, because many of you being mums may not just be first time mums, but you might be second or third time mums and wanting to kind of think a little bit further ahead. So myofunctional therapy might be a new word for some of you. Basically, just a quick definition of that is basically the retraining of your oral facial muscles, so your lips and your cheeks and your tongues, your tongue, basically to create a positive effect on the growth of the development of the face and the airway. Myofunctional disorders are basically habits that are created over time, so they're incorrect tongue postures because of maybe a thumb or a dummy, or because of their tongue tied, so they're speaking funny. There's all sorts of habits that can be created over time, and a myofunctional therapist is trying to get those back to where they should be to create a positive effect to the growth. So the earlier growth can be corrected, the earlier function can be corrected, the faster you're going to get back on track, and then you're going to get optimal growth. So key important things to hear is that actually 60% of the craniofacial growth happens in a child by the time they're 4 years old. So already you're over halfway there to your adult facial structure. So if you can get it right as soon as possible, then you're going to be more likely to get optimal growth and function, and it's 90% by the time you're 9 years old. Hence why we kind of have an approach of the earlier you can get function right, the better your results are going to be, rather than waiting until you're 15 and pretty much fully developed and grown. So just one of our main philosophies here is what we call the big three. And key things to remember, so is we really want nasal breathing. That means breathing through your nose. It helps develop that upper arch and growth and development forward. So just a quick, I suppose, picture. So I'll let Laura put that up to the camera. So this shows a boy at 10 years old who is breathing through his nose. He got basically a gerbil when he was older, which he had a allergy to, and because of the allergy, he no longer could breathe through his nose, and so he started mouth breathing, and that changed his face shape. So you can see the change in his face, which makes him is less than optimal. The second, so we've got nasal breathing. The other important thing is lip seal. So your lips basically are like an orthodontic appliance, where they actually help they can either put too much pressure or not enough pressure to help create where your teeth and where your jaws are growing to. So the big three is breathing through your nose, lip seal, and then correct tongue posture. So if you don't have a correct tongue posture or swallow, then that's also going to push against your teeth or your jaw in a funny position. So it's about that balance of where your lips are and your tongue is. So ideally we want that tongue up in the roof of the mouth, so so that it can basically develop a nice broad arch. So I'm just going to show you another quick photo which shows you how a tongue posture can affect where your teeth go.
That's incredible.
And some of this stuff is just treated with a myofunctional therapist, not always, or with a what we might call a myo brace, not actually with braces. You don't necessarily have to have braces, depending on the age of the child and how severe it is, to actually get that straight teeth. If you can correct the function early enough, then often you can avoid those things. So big three: nasal, lips, and tongue. I can't stress that probably enough. So very quickly before I get on to actual baby lip and tongue ties, just something that we look for in kids, but also you could look for in younger children as well. But when we're doing our consults, things that we are concerned about or looking at, I'll let you have that picture again. So these would be concerns or problems that you might see in a child, would be that mouth open posture, whether it be during the day or at night time. So like I was saying, we want that lip seal. You might see they might have very large tonsils, which is causing them to be mouth breathers or not be able to close their mouth and breathe through their nose. They might have constantly dry lips or chapped lips. So sometimes the mouth open posture is not really, you can take the way if you want to, but it's not like a really dropped open mouth, but sometimes can just be like a paper thin opening. But if they're having to use chapstick all the time, you shouldn't generally have to be. That's a sign that they're breathing through their mouths. Obviously we're looking for malocclusions or the incorrect bites. We're looking for high palates. If they're dribbling at night time, snoring, if they're having speech difficulties, if they have difficulties swallowing pills, they have a flared upper lip or a short upper lip, or very high smile line, whether they have any habits, whether it be nail biting, finger sucking, there's all sorts of habits that can go on, whether they do have a tongue or lip tie, whether when they're swallowing you can see any action going on in the face. So ideally actually when you swallow, no one should know you swallow. So when you swallow, if all your muscles are functioning correctly, then actually it shows nothing in your face. But often when you see kids, because they have a funny tongue posture or things going on myofunctionally, you actually see some tension in the face when they swallow. So we're looking for things like that. A forward head posture, which tells us a little bit about the airway. We're also looking at your jaw problems, or whether there are any clicks or deviations when they open. And then also whether they have any headaches. So we're looking at a whole range of things, and this is actually more in our children when we're doing our consultations, but some of these things you could probably pick up quite early on, so it's nice for you guys to know about. But let's get on to babies, because that's probably what you're most interested in, and I just thought we'd really quickly go over, people often want to know, or you want to know what to look for when you're looking at your baby, whether you think it could possibly be tongue or lip tied. The hard thing is with the tongue or lip tie is that it's not just on how it looks. Some of the more severe ones, definitely you can look at them straight away and say you said tongue or lip tied. But when we start talking about posterior tongue or lip ties, or less posterior tongue ties anyway, we start to need to take a bit more of an extensive history, and it becomes a little bit more about the signs and symptoms that we see in mum and in baby as well. So that's when I suppose your consult or seeing your lactation consultant and things like that become more important. But let's just have a look here, Laura. So you can see the little baby that has the tongue all the way up, nicely curved oval tongue. That's normal, okay? When you were looking over at the other two, you've got grade 1, which is right onto the ear on the side of the page. That one there, yep. And then also grade 2. So those two are quite obvious in the mouth, and you don't really need to be looking at any signs or symptoms too much that baby is tongue-tied. Okay. The ones on the bottom are becoming a little bit more towards the posterior or towards the back of the tongue. This kind of depends a little bit more on how tight it is and the function or how far they can stick the tongue out, things like that. So sometimes when they're in the back, it can be really loose and it's not a problem. Sometimes it's very tight and it's still an issue because the back of the tongue for the baby can't get up. Also, you'll set the top of that page, although they won't be able to read it because of the camera.
I can put it in the comments after.
We'll put it in the comments. Just some of the things that the signs and symptoms that you might see in mum or baby. So I'll just list them off really quickly, and Laura's going to put this up on the comments later. But for mum, if it's painful, so breastfeeding actually shouldn't be painful. If they're actually getting grazing or cracking, anything like that, that shouldn't be happening either. If you're getting blocked ducts or mastitis, if you're having low milk supply, if you're feeling frustrated, disappointed, discouraged with breastfeeding, so if you're getting kind of down every time or wanting to almost avoid breastfeeding because it's not going well, that's a sign that there may be something going on. Or if you find that you have to wean baby early. So those are some of the things. There's actually a longer list, but this is a good start. And then in babies, you might find that they have a poor latch. They don't suck very well. There's clicking when they are nursing. They're not getting very good weight gains, or they're having weight loss. You're not feeling like your breast is drained very well, so you're not getting good milk transfer. They can be irritable or have colic. There can be fussiness. They can be arcing away from your breast. They can get tired, so fall asleep at the breast quite often, so they'll be hungry, feed for a little bit, then fall asleep, wake up and want to be feeding again. There can be difficulty establishing suction, so they're just not getting a really deep latch on the breast, and they can slide off, or they chew on your nipple rather than actually like latching properly. So those are just a few of the signs and symptoms. But like I said, there's with those grade 1s and 2s, when they're right close to the tip of the tongue, from our, say, more orthodontic perspective, but also for speech problems and ability once they start solids and being able to cope with different textures, I would definitely treat those. The more posterior ones, one, they need to be examined by a professional, but two, we kind of look at the signs and symptoms of what's going on between mum and baby as well. Let's just have a quick look at the lip. So the two top photos are actually grade 1 and 2, which we don't treat. So nice flexible lip, the tie doesn't come down to the ridge, it's not causing any restriction there. And then the bottom two, we've got a grade 3, and which goes bit of tightness that goes down to the lip, down to the ridge, and then we've got a grade 4 which tucks right down up underneath. So generally, and the blanching as well as noticed. Generally we would treat a grade 3 and 4. There's been a little bit more research done recently where a grade 3, even sometimes we will, depending again how it looks and the mobility and flexibility and things. So again, that one is one that some we would treat and some we wouldn't. It again depends on signs and symptoms, and we would have to examine that one to know. Grade 4, the one that tucks right down up underneath, those are the ones that are probably going to cause your gaps between your front teeth when they're older, and definitely, and even sometimes I've had mums say that they get almost like an indentation where the baby is, instead of latching with the lip, they're latching almost with that upper arch, and they're getting like an indentation where that lip tie tucks under onto the arch. So if you're getting that on your breast, that's a sure sign that there's probably one there. So how do we treat it? We ideally, the earlier the better, as we said, and often with say a newborn, if you treat it nice and early, they don't need to really retrain how they latch because they're still learning anyway. The older the baby, sometimes it can take a little bit longer to get the effect. So if they're over 3 or 4 months, it might take them a few weeks before they actually change how they're feeding, so it can take a little bit longer. We just for the mum and baby and for our own ease of treatment, I would say ideally before they're 3 months, but again, ideally before they're 6. Once you're over 6 months old, it can be hard for mum or dad to do the exercises afterwards. And it's just like a little bit more traumatic for the child because they're much more aware of what's going on. We do use a water laser here, so reasons why we use a water laser, because it has a little bit of water when you use it, it actually has a bit of a cooling effect, so you tend to get less scarring or less tissue damage. It's also a nice cooling effect for whoever the patient is as well, the baby or adult or child, so that you actually aren't getting as much heat created, so it actually keeps the surface nice and cool and so they don't feel it as much. You also don't, it's not a single cut which you would get with a, let's say, scissors release, so you are less likely to get healing back down because you get, it's called secondary healing rather than primary healing, and you're also less likely to get bleeding as well, just because it basically cauterizes it kind of as you go. So those are kind of the main reasons why we use a laser. You also have a lot more control because it's controlled by a foot pedal. You can kind of do a little bit, and if baby was, let's say, to move, or basically if you want to check it, you can do a little bit more, whereas if you say use scissors, you kind of get one opportunity and that's that. If you don't get it all, you don't get it all. So I think that we're able to get a thorough job, especially if you're doing those posterior ones. We do give post-operative exercises, which are important. We say for 3 weeks, just to actually help keep that open so it doesn't heal back down. You can also, we generally recommend seeing a lactation consultant, especially for first-time mums, and also a craniosacral body worker, so that's either an osteopath or a chiropractor, because the tongue is a muscle that is attached to lots of other muscles, and so it's not always just fix that and that everything's done. It is for some babies, but sometimes there's tightness in the neck depending on how they're born or what position they've been inside you, or around other areas of the face, and so they will actually help release that as well, and so it works really nicely together as a conjunct to just help release more tension as well, and then obviously work with your midwife too. So we try and advocate for a team approach. It's not just kind of come and get it done and everything's done. It is, because as everything with being a mother or having a baby, it can be more than one thing, so you kind of need to look at the whole picture and treat it holistically, as we have said. I think that's pretty much it. Have I forgotten anything?
No, it's pretty good, yeah.
Yeah, so we always do a week follow-up as well. So you come in for your consult. Usually you can have it done that day if you do want to, or you can come back and have it another day. And then we usually do a week review as well, just to check, one, how the exercise is going, but also just a follow-up on how everything else is going with the feeding. And yeah.
Oh, yeah, and I know I can, like, personally, because I've had both my boys done by Eddie, and they just, like, wrap them up, take them away, and it's within minutes they're back. And, like, both times Billy and Taylor have both come back and they're, like, settled and basically still asleep. So it's really quite gentle, and I feel like they haven't really had pain. Like, the exercise afterwards would probably be the hardest part, I think.
It definitely is. So I've had my own baby done as well. I didn't do my own one. Maybe I will the next time. But I definitely think probably the exercises are harder for you and for your baby than actually having the procedure. The baby actually, some sleep right through it, but if they do cry through it, it's generally actually because you're holding them still and you're holding, you use your thumb to hold their mouth open. So obviously that they don't understand and makes it more, it's more about that than it is actually about the procedure itself.
Yeah, and if they're hungry or something, they're like...
Yeah, and sometimes, they're hungry.
I think we've got it down to pretty fine art.
Yeah,
now,
we do.
Know everyone's job and we know what we have to do, and it's very quick.
Yeah.
Like a lot of parents, I think, look on YouTube at different clips and things and have this idea of what it's going to be like, but it's completely not like that.
Yeah.
It's very quick and easy, generally.
Are there any burning questions on thing? Or we do have a list of questions that we sometimes, like, that mums and dads often ask during our consultation. So like some of our most commonly asked questions.
Yeah.
We can answer those if you'd like to, or if there's any that have come up on the page.
I have a couple from a couple of mums who were in before we started. And yeah, guys, if you do have anything, honestly, just ask because we can get it answered for you. It's a great chance to do so. So one of the questions that came in prior was, how does your approach differ from an ear, nose and throat specialist who also takes referrals for tongue and lip ties?
So the difference between us and an ENT, an ear, nose and throat specialist. One thing I would say is that we probably do this more often than they do. So I'd say we've probably got it, the process down to like a finer art. But we do advocate more of a team approach. From what I've heard, I mean, I don't know, I'd say that different ENTs all work differently. So don't quote me on how they work or whether it's different. But I don't know if they'll be sending you off to your lactation consultant quite the same or doing the post-op exercises, or whether they do a week review. Not usually with surgeons. I don't think they usually would review that.
It's really hard to comment, really.
Yeah, it is hard to comment because each one probably does work differently.
And it's not really out.
They might be more likely to treat like a 1-year-old, let's say was very severely, and they may put them under general. So we wouldn't be putting our kids or babies under general. We do sometimes treat, so we can treat over 6 months old. Generally, unless it is an anterior, so one of those 1 or 2, we have treated a few that are, and actually generally they're pretty good. Sometimes we will use some topical gel, and we haven't really found it to be too much of an issue actually. If there's a topical gel, then they actually, my last one was really good actually. He was completely fine. But otherwise we would recommend that they be say 4 or 5 years old, just so they understand a little bit more what's going on and you can talk to them. Yeah, I'm just trying to think whether we've answered the question.
I feel like that's pretty good. It would be hard to say
because
different surgeons would treat differently. Yeah, and some ENTs might use scissors, some might use a laser, some might.
It's hard for us to say, really.
Yeah, they might use electrosurge. Yeah.
Oh, that's awesome. So the next question, how would you judge cases of older babies with tongue ties? So would you laser older babies where the main issue was weight loss and or slow weight gains caused by a tongue and lip tie?
So an older baby, I mean, what would you call that? Anything from 5 months through to a year? I don't know. So generally, actually, you either say, most of our patients, they either come in right near the start of their journey, so within the first 3 or 4 weeks, and that's because they're having pain or mastitis, things like that, and so it's treated early. The next stage we generally have people come in is around that 3-month mark, and that's often because that's when the weight gain issues are a problem, and that can be because basically at 3 months your hormones are changing as your mum, and so no longer are your hormones really stimulating your milk supply, instead is your baby stimulating your milk supply. And so if they're not stimulating you enough or draining you down, then that's when you start getting the weight loss and the low milk supply. So actually we usually see that about that 3-4 month mark. You don't usually see that later, after 6 months or so.
Generally because they're on solids then.
They're on they're starting solids then. So yeah, the weight loss thing doesn't generally happen like at 8 months old. It usually would happen at about the 3 months where they just seem to halt for some reason.
I reckon between like 8 weeks and 12 weeks, like we do see a big amount of babies that age and get great response too from treatment. Like, you know, the mums really had supply issues or really struggling with pain, absolutely, and the baby does seem to kind of really stagnate with the weight gain, and then they are treated. Some of those babies could take a couple of weeks to kind of change their technique that they've been feeding with, but absolutely then a lot will really come away and put on weight well.
I think, like, this is me jumping in with a question, but when you're talking, like, babies that haven't been treated and moving on to solids, you sort of touched on that feeding solids can become a problem. What would you be looking out for there?
So sometimes we have it that a child won't take anything except for like liquid food, I suppose. So if they're struggling with different textures, I would say that's where you see it more in the older kids.
Generally, like the back of their tongue hasn't stimulated the back of their palate enough to desensitise it, so they gag on food because they've never had anything kind of.
Well, it's normal to get some gagging.
Yeah, absolutely.
But if they're almost fearful to go towards more textured food, then that would be a concern, because like they're concerned that they're almost like they're going to choke. They're doing it almost as a protective mechanism. Yeah, that's really what you're looking for. It can be hard because sometimes they're just stubborn.
It's totally
yeah.
Another thing to note is that, like, so a lot of this is based around anatomy, like baby's anatomy with mum's anatomy, and as you know, like from doing this job, mum's breasts and things are just so different, you know, and like a baby, I kind of call it a variation of normal, that tongues come in all shapes and sizes as well. Some are really long, some are really short. And sometimes you strike a really short tongue with a mum that may have flat nipples, you know, that kind of comes into play as well. So it's not the same for everybody, and we really have to treat, you know, every baby as they come.
Yeah.
You know, and we sometimes will get mums come in, or grandmas that come in with mums and say, look, I fed all my babies fine, they were completely fine, I had no issues. You know, she may have, you know, had really good breasts, you know, that really relate. Babies feed really well on those, but it really is just case by case. You know, it's not just your baby's got a tongue tie, we've got to treat that. It's not that at all.
Yeah.
And we do send, you know, quite a few away that don't need to be treated, so it's not like we're treating everyone that comes in as well.
Yeah.
It really is case dependent.
Yeah, that's really great. There have just been a few questions popped up. So from Amy, how common is it for posterior tongue ties to be misdiagnosed by lactation consultants? Or misdiagnosed, I suppose, by others that you might
that's
see.
a hard one.
It's really hard. I think a posterior tongue tie doesn't always, it's not easy to...
I would say, I'd say there's no stats on that.
I suppose, like, another way you could put it, like, how many would you see, like, who have been for other, like...
being told no, and then we have done it, and
maybe
improvement.
that would be an easier way to.
Quite a few that have had various opinions, and I don't think it's fair as a practitioner to say that they were wrong. You know, that's not what it is. Again, it's absolutely, and you just have to take the symptoms on board. And some people that are really adamant, they come in, my baby's got a posterior tongue tie, I want it treated, and we have to say, well, look,
it may not make any difference.
Yeah.
But then we get plenty. It's where every mother and baby kind of combo is different, and we do get plenty still that it is treated, and they just say, "Oh, it's a world of difference."
Instantly too.
So, yeah, it's a hard one. I suppose if you've tried everything else,
my advice is like, mums, no. Like if you're not happy with the opinion you've got, there's no harm in getting another opinion done, you know.
You know your baby better than anyone else.
You do, and it should be an enjoyable experience to breastfeed. It shouldn't be something that you are struggling with, you know. So if you're really unhappy or unsure, just get another opinion somewhere else, you know. No one's right or wrong, you know. Like it's not my place.
Like raising children, there's no one way.
Absolutely.
That's cool. So our next question from Ginny. My daughter had lip tie snipped 3 weeks ago and posterior tongue 2 weeks ago. She is now 10 weeks old. There's not much improvement. She still slips and makes clicking noises. Is that normal?
I would say she shouldn't be clicking.
I would say definitely the clicking.
That doesn't really sound normal. I don't know when you had it done, but I would ask for it to be reviewed or checked, especially because it's still not that long since it's been done. They potentially might just be able to stretch it out rather than having to have the whole procedure done because it's quite fresh. And I would see a lactation consultant because sometimes it is a positioning issue. If you're holding your baby quite a long way forward rather than actually, ideally you want a bit more of a laid back position. Your baby may be working against gravity, and if they're working against gravity, they're gonna probably be clicking more as well.
And possibly osteo or
and
body worker.
Consider whether you've seen an osteopath or a body worker as well. So I would get checked.
Yeah, I would.
Oh, thank you. Jackie has just asked, my 9-month-old has a lip tie, maybe a grade 2 to 3. Her front teeth have come through and are quite wide apart. Is this okay?
Yeah, I wouldn't probably, especially not a grade 2 or 3. You want there to be spacing between your baby teeth, so I wouldn't be concerned if your child first teeth come through with a space between. You actually want that, and often that doesn't close up. Even when the adult teeth come through, sometimes there's still a space. Often that doesn't close up until the eye teeth come down the side and kind of closes everything together. So spaces are a good thing. You don't want your baby teeth, actually it's a problem if all the baby teeth are like very tight together.
I would say definitely get it reviewed before like around 4 or 5.
Yeah, so especially with that, I would say, how did they say their child was?
9 months.
Oh, 9 months.
Yeah, so I wouldn't probably rush in to get it treated at 9 months, especially grade 2 or 3. I would have it looked at when they're, say, 5 or 6 years old, to have it reviewed.
Awesome, thank you. So Kayla has said, hi, if a baby has a stage 4 lip tie and has had it snipped, can their speech still be affected later in life?
I would say most likely no. It would be, once it's treated generally earlier, then, those fibres would have released enough. And it's,
generally lip ties are not so not likely to affect speech as much as a tongue tie. It's more going to affect them, one, if they're breastfeeding, and 2, with aesthetics, because it's going to be like a gap in the front, but less likely to affect speech. You can get sometimes decay problems if they've like grade 4 lip and they actually can't brush very well up the top or clean up there, so decay can be an issue, but less likely to be a speech problem.
Awesome. Tyree has asked, my 6-month-old has had his tongue tie and lip released 3 weeks ago. Everything has improved, yay, but they both look like they have reattached. Should I get redone or will it be fine? And also, do I continue to do the exercises?
I would say, again, if you're unsure, go back for a review and have it looked at. I can just say from personal experience, actually, with my own daughter, so even though we recommend the exercises for 3 weeks, I found that even after the 3 weeks, maybe once a day, or every other day, maybe just before a feed, I would actually give my daughter a stretch under the tongue. Not because it was all healed up, but it's almost like stretching a muscle or stretching a ligament before doing any kind of exercise. It would almost remind her that you can actually get that tongue up. So it doesn't hurt to do the exercises even after that time.
Good that the symptoms have changed, though. I mean, that's really positive. So
obviously, it hasn't reattached completely, because if the symptoms would still be, there more.
Yeah. Another one. Can a tongue tie be confused or misdiagnosed with reflux?
Well, I'd say it probably could.
Yeah, probably.
I mean, it could be a cause, but it also may not be the cause of the reflux. So again, I suppose you know your child, and you need to kind of check a few different avenues. That's where I suppose working with the body workers, they will check if there's something. Sometimes it's something going on further down, if it's especially things like reflux. And talking to your blanket nurses and things like that.
going to say, a lot of mums will come in, particularly with the babies that have got lip ties, because their lips are tucked right in when they're feeding, so you can't see the colour of their lip, as it's not flared out. Often the babies that their lips are right in, they're sucking in a lot of air. So as the baby's feeding, their tummy's filling up with air, and then obviously they need to burp and get that out, and often they will vomit quite a lot with that air coming out because it has been trapped down there.
Just brings everything
up with it. It brings everything up with it. Now, I suppose that's something we find interesting, I suppose, information that we haven't said is that we find more like gas issues and things have been more related to the lip, whereas pain and clicking and not draining very well maybe would be more related to the tongue.
Alright, and then we've just got a couple more questions that are sort of the commonly asked ones, I suppose. So will my baby's speech be affected if I don't treat tongue tie?
Well, I guess it's case by case as well for this, so we can't kind of give anyone a 100% answer that yes, this is going to affect speech, or no, it's not. But generally speaking, the tongue ties that are right to the tip, the grade 1s and 2s, are far more likely to affect speech than what a posterior tongue tie would, purely because that tongue, it just can't move. It's really locked down, and particular sounds they really can't make without moving the tip of their tongue. So again,
so the more anterior, the more likely, but then again, everyone's a bit different.
Cool. And one that gets asked a lot, my GP said that tongue ties are a fad and they don't need to be treated. What should I do?
Answer that.
Well, I mean, even studies have shown that they think at least 10% of babies, and that's like studies through hospitals and things. Even when I think they change the criteria a little bit, I think they still come around that ballpark figure. And I actually think it's more that in the past they were never looked at, and there was say in the 80s, lots of people bottle fed a lot, and now that there is such a push for breastfeeding, I think that mums are saying, well, why can't I? And so it's being found more because it's just being looked for, whereas previously it wasn't looked for. Hence we have lots of adult dental patients that have tongue ties, and we treat those as well. So I would say it's not a fad. Potentially it's just a result of the fact that people are breastfeeding more.
Totally. And I was just going to say, so often mums will come in with their babies, and the mums will bring their mums with them. So we've got a lot of grandparents that come in, and I think when we're explaining to the mums about what's happening and how their baby's feeding, the grandmas and the nanas in there, they're sitting there thinking, this happened to me, like I couldn't breastfeed my children, and we'll look in the mums' mouths and they've got tongue ties and lip ties, that were never looked at. Or so I don't think, exactly what Abby said, I don't think it's more common than what it was. I think that the numbers would still be the same, but they're just being picked up. People are aware of them now, midwives, and they're picking up on it straight away. Most
and
cases.
I think that sort of mentality around breastfeeding's just painful has changed. Now we are aware that it shouldn't be.
Totally.
And more people, I suppose, are aware, and the professionals are aware. So we're getting a bit more into the nitty gritty of how can we fix that and what might be going on. Cool, that's awesome. So we spoke briefly about this. Will my baby have a big gap between their front teeth if I don't treat a lip tie?
So that depends again. Like I said, I suppose we did kind of go with that. With the grade 4s, I would say that more than likely your child will have a space, but not always. They do tend to grow up with time. But grade 4s are usually well attached right underneath the arch. I would say that again, those at the grade 3s are the ones that are always, say, on the fence, where some of them will cause a space and then some of them will not. And 1s and 2s will definitely not. Well, it'd be very, very rare for that to happen.
I was just going to say, sometimes even the grade 4s that are really wide and thick, yes, we can release them, but I would always say to parents, get them reviewed again, around 4 or 5 before their permanent teeth come through, just to make sure that, if there's any fibres that are left or it's tight, then we could, possibly just, see what we could do for that.
Yeah, awesome. And does it hurt the baby during the procedure?
So, as we said prior, I think that it's more uncomfortable for them because the way we're having to hold them. I think that maybe it's a little bit uncomfortable. So we've treated, say, 3 and 4 year olds, and I've had myself treated actually, just with topical. It does feel like a slight kind of like a tapping or a stinging. So let's say we treated a 4 year old and we did it with absolutely no local, and she just said, oh, it was a little bit stingy. Like, she was completely fine. So it was quite good hearing that from a child, because then you do know exactly how it does feel. So they do feel a little bit, but actually I think that it's more the way that you're holding them. They're more concerned about that than the actual procedure itself.
A lot sleep through.
A lot sleep.
They don't even wake up. And if they do get upset, it's so quick. It's like 10 or 20 seconds, and then they just come straight.
As soon as you pick them up, which tells you kind of more. It's more the way they're being. They
don't like their mouth being held open. They just want to.
Which is only natural.
Yeah. Cool. And I just saw one last one has popped up. My baby has a grade 3 posterior tie and a suspected lip tie. He is 9 months old, but has only recently been diagnosed. We have had a lot of feeding issues. Is this too late, or should it be lasered?
I would probably recommend a consult for that case, just so that we could probably know a little bit more about signs and symptoms.
Totally.
And then we can have a good look at it as well. Yeah.
Like Abby said before, like usually we would only treat the older babies if it was really symptomatic, if there was big problems and things. So, but totally we would have a look and.
Perfect. So that is all of the questions that we've got there. So unless anyone else can put one up in the next couple of seconds, we'll just sort of finish it there, and thank you guys so much for meeting with me. Tongue ties, lip ties are always popping up in our Milkbar Mum chat, so I thought it would be awesome to talk to the professionals. You guys do this all the time, so it's really cool that you've taken your time out to have a chat with us, and thank you very much. And thank you guys for all coming and taking part and having a look, and hopefully you take away something really good from tonight, and have a good weekend. Bye.
See ya.